Rashid Mahmood Sahab, start the Holy Quran.
Right. बहुत शुक्रिया सर. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. وقل للمؤمنات يغضضن من أبصارهن ويحفظن فروجهن ولا يبدين زينتهن إلا ما ظهر منها وليضرب إلا ما ظهر منها وليضربن بخمرهن على جيوبهن صدق الله العظيम. ये कुरान मजीद की सूरत नंबर 24 है, सूरत अन-नूर. ये उसकी आयत नंबर 31 का कुछ हिस्सा पढ़ा है, लंबी आयत है. इसका तर्जुमा है, और मोमिन औरतों से भी कह दो कि वो अपनी निगाहें नीची रखा करें और अपनी शर्मगाहों की हिफाजत किया करें और अपनी आराइश यानी जेवर के मकामात को जाहिर ना होने दिया करें मगर जो उनमें से खुला रहता हो, और अपने सीनों पर ओढ़नियां ओढ़े रहा करें. सदक़ल्लाहुल अज़ीम.
जज़ाकल्लाह. प्रोफेसर राशिद साहब, बिल्कुल कुरान एक राह हिदायत है. हम स्टार्ट इसलिए करते हैं. टुडेज वेबिनार, इट इज़ द कंटिन्यूस एफर्ट्स ऑफ PMA and Pakistan Physiological Society, Pakistan Association of Pathologists, Azad Jammu Kashmir Medical College, Muzaffarabad, and Women Medical College, Abbottabad. Professor Salma Kundi, highly obliged. You are supporting this program. I hope, inshallah, may Allah give you the long life. Today's activity is divided into multiple portions because the breast cancer is one of the commonest causes and one of the leading cause of death, not only in Pakistan but also all over the world. हर 13 मिनट के बाद जैसे एक खातून इसका इन्वॉल्व होती है, और हर 10 में से 9 में से एक खातून जो है ना उसकी डेथ हो जाती है. तो Azad Jammu Kashmir Medical College has started this activity from the whole month. This October is dedicated to the breast cancer. So we planned this program in multiple. First of all, we started this in the CMH. Then we started it, celebrated in the AIMS. And now with the collaboration of medical college, whole the week we have dedicated for the breast cancer. So first of all, I will invite Professor Iram Gilani. Professor Iram Gilani is the graduate of Abbottabad Medical College. She is PhD. She is head of the Department of Community Medicine, and she is also master in medical education. Over to you, Professor Iram Gilani, on the aspect of prevalence and factors within 6 to 7 minutes. Thank you very much, Professor Iram Gilani.
Thank you, sir. Sir, is my screen visible to you?
Yes. अब इसको स्लाइड शो पे कर दे जरा.
जी सर, कर दिया सर.
नहीं, आप इस पे आ रही है नीचे, वो कप जो बना हुआ है वहां पे आए.
सर जी सर, मैंने कर दिया सर. स्लाइड शो पे नहीं आ रहा. आप वंस अगेन कर लें. वंस अगेन कर लूं. ओके.
हाँ, इसको जोर से दबाएं. यहाँ पे नहीं दब रहा.
नहीं सर, मेरी तरफ से तो आ रहा है. चले मैं
नहीं, यहाँ नहीं, उधर ही. चल, लेट्स स्टार्ट इट. कोई बात नहीं.
आपको बिल्कुल नजर नहीं आ रहा?
नहीं, नजर तो आ रहा है, लेकिन उसके अंदर नहीं है. आपको स्लाइड नजर आई? स्लाइड मोड पे नहीं है, प्रेजेंटेशन मोड पे नहीं है.
अच्छा सर, स्टार्ट कर दूं मैं?
जी कर दें.
Respected Principal Sahab and my dear colleagues, my name is Dr. Iram Gilani. I am teaching as Associate Professor in the Department of Community Medicine and Public Health at AJK Medical College, Muzaffarabad. Today, I'll talk about breast cancer prevention and control. Just being a woman is the biggest risk factor for developing breast cancer, because increased risk of breast cancer is linked with being exposed for a long time and to high level of female hormones. In women, normal phases like the menstrual cycle, pregnancy, breastfeeding, and menopause are also associated with fluctuations in estrogen and progesterone levels. While men do develop breast cancer, but less than 1% of all new breast cancer cases occur in men. Coming to breast cancer statistics, breast cancer is the most common malignancy occurring in women.
Professor Iram, your slides are not moving.
Sir,
Move नहीं कर रही.
yes, sir, मेरे पास तो move करे. I don't know okay, what is the problem.
आप एक दफा इसको खत्म करके दोबारा इसको शेयर करके
Okay, stop share करूं और सर
दोबारा शेयर करें.
दोबारा से शेयर. सर वो शुरू में जब हमने किया था तो उस वक्त तो शेयर हो रही.
अब करें जी. अब इसको स्लाइड मोड पे ले जाएं. ठीक है. अब ठीक है.
अब ठीक है सर.
अब ठीक है.
थैंक यू सर. सॉरी सर, लेकिन मैं अपनी तरफ से ठीक किया था मैंने. ओके, continuing with the breast cancer statistics. Breast cancer is the most common malignancy occurring in women worldwide. In Pakistan,
प्रोफेसर गिलानी, अब ये ब्लैक आ रहा है, टोटल ब्लैक आउट है.
It's not visible.
ओके, ब्लैक आउट है.
Sir, I don't know.
पुराना तरीका ही ठीक था जो आपका वो.
It's not visible.
नहीं, ब्लैक आउट है.
सर मैं अपनी फिर वीडियो बंद करती हूँ.
अब ठीक है.
ऐसे कर ले. अब ठीक है, ऐसे कर ले.
अब आ गया.
अच्छा, अब मुझे नजर नहीं आ रहा. आप लोगों को नजर आ रहा है, मुझे नजर नहीं आ रहा.
अच्छा चलें, आप दोबारा ट्राई करें इसको.
सर हमने जब उस वक्त किया था ट्रायल,
उस वक्त तो ठीक था. अच्छा कोई बात नहीं, ये आईटी का यही प्रॉब्लम होता है.
क्या करें सर फिर?
आप एक दफा इसको आउट करके दोबारा स्क्रीन शेयर करें. आप ऐसे बोलते जाएं. चलें, आप ऐसे अपने सामने रख के बोलते जाएं. आप ऐसे बोलते जाएं. ठीक है,
ठीक है सर. ओके, continuing with the breast cancer statistics. Breast cancer is the most common malignancy occurring in women worldwide. In Pakistan, everyone.
गिलानी, ब्लैक आउट है. We are hearing your voice, लेकिन looking nothing.
सर ये I'm sorry but मुझे नहीं पता.
आप ऐसा कर लेना, आप अपने पास रखें.
जी सर.
और आप बेशक उसको, आपकी आवाज तो क्लियर आ रही है, आप बिल्कुल स्क्रीन शेयर ना करें. कंप्यूटर अपने लैपटॉप पे, लैब पे रख के ना उसको बोलना शुरू कर दें. तो रिकॉर्डिंग हो रही है ना, आप बोलना शुरू कर दें ऐसे ही.
सर मैं ऐसे ही कर रही हूँ.
हाँ ठीक है.
सर आवाज तो आ रही है ना?
क्लियर.
अच्छा सर, मुझे नहीं समझ आ रही क्या मसला हुआ है. ओके, so continuing with breast cancer statistics in Pakistan, every 1 in 9 women has a risk for developing breast cancer in her lifetime. A woman with cancer in one breast is 3 to 4 times more likely to develop new cancer in the other breast or in another part of the same breast. In contrast to the West, younger women are being diagnosed with breast cancer in Pakistan despite having no risk factors. Therefore, for our country, early detection of breast cancer is recommended. Coming to early detection of breast cancer, it is done through a screening test which is called mammogram, and it is used to identify those women who should have additional testing to determine the presence or absence of the disease. And screenees are sorted into 2 groups after mammogram. One group contains those with a negative test and the other one those with the positive test. Women with negative tests, there is nothing suspicious in these women with negative mammogram test, and they do not require any additional medical attention. Whereas women who are positive for mammogram, there is some suspicion for their cancer in their breast, and they require active surveillance through a schedule of minimally or non-invasive testing to monitor for clinically important changes in their breast. Now coming to the concept of surveillance and control, in connection with breast cancer prevention, surveillance identifies opportunity for prevention and control of breast cancer by continuous systematic collection, analysis, and interpretation of data. An effective national cancer control program in Pakistan may integrate the breast cancer surveillance, prevention, early detection, diagnosis, cancer registration, and treatment. And term disease control in connection with breast cancer prevention, it denotes ongoing operations aimed at reducing the new cases, which are also called incidence of breast cancer. In connection with the prevention of breast cancer, it is very important to create awareness regarding the risk factors of this disease. There is a misconception that breast cancer is entirely a hereditary disease. While 90 to 95% of breast cancer cases, they are not hereditary. Only 5 to 10% of the breast cancer cases are due to gene defects. And in these 5 to 10% of the breast cancer cases, risk of developing breast cancer is doubled if a female's 1 degree relative is diagnosed with breast cancer, and this risk goes up to 5 times if 2 of her 1st degree relatives are diagnosed with breast cancer. So coming to preventive actions against breast cancer, they may be planned at 4 levels of prevention for convenience, but these 4 levels, they would blur or overlap into each other. Primordial prevention of breast cancer will address risk factors at the systemic level, that is at the policy or legislation level. And this primordial prevention, it will inhibit the establishment of risk factors known to increase the risk of this disease. One of the example of primordial prevention for breast cancer will be promoting healthy lifestyles in adolescent girls, healthy adolescent girls, through awareness programs in colleges, in social media, electronic media, etc. And coming to primary prevention for breast cancer, it will target on modification of modifiable risk factors in females, like cutting back on sugar, decreasing intake of red meat, getting quality sleep, stress management and stress reduction, and secondary prevention includes screening that I have already described, mammogram through mammogram. Secondary prevention would aim at preventing breast cancer by early detection, and this is important in those women who have non-modifiable risk factors, such as family history, advanced age, inherited genetic mutations, BRCA1 and BRCA2 gene mutation. And tertiary prevention of breast cancer will include improving quality of life of breast cancer patients by their effective management and rehabilitation, and it can be done through peer colleagues and support groups, and it can also be done through strategies to avoid recurrence of their breast cancer, and vocational rehabilitation programs. I'm sorry, my slides were not visible. This is end of my presentation.
Thank you very much, Professor Iram Gilani. No doubt that is the main pitfall of the drawback of the IT system. We heard everything clearly, Now I will request Dr. Naheed, because one of the important factor is how to assess the breast, and assessing the breast and early detection of any abnormality in the breast is very important. So Dr. Naheed is Associate Professor of Surgery, and she and Dr. Fazana both are related with the breast cancer program in Azad Jammu Kashmir Medical College, Muzaffarabad. I salute to them because they are hardworking from the so many years. And also I'm supporting them because they are the more future of the Azad Jammu Kashmir Medical College, Muzaffarabad. Professor Naheed.
Bismillahirrahmanirrahim. Assalamu alaikum.
Walaikum salam, beta.
Thank you very much, sir, that you have given me a chance to talk about such an important topic on this a very nice forum. Sir, can you see my slide?
Yes, sir, everything is clear.
Okay, I'm Dr. Naheed, Doctor Associate Professor of Surgery in AJK Medical College. So before proceeding to the diagnosis of the breast cancer, I would like to discuss briefly the clinical presentations, that is the symptoms of the breast cancer. The first most common symptom with which the female patients present to us is the lump or some thickening, feeling of something in the breast. This can be very small, this can be large, and most of the time they give us a history of very small time, like I felt it about a week ago or a month ago. But the size of this lump never coincides with your history. Second most common presentation is the change in the size or the shape of the breast in comparison to the other breast. Most of the females present to us that when they examine their own self in comparison to the last month or in comparison to the last year, their breast size is increasing or its shape is changing day by day. Then changes in the appearance of the nipple. That especially in those females in which there was not congenital retraction of the nipple, they present with the retraction of the nipple or the form of the split-like nipples. That they give us the history that initially it was normal. They were able to feed their babies normally, but now the shape and the size is changing. If they have newborn babies, they can't feed them properly. Then discharge from nipple is a very common symptom in over area. This discharge initially milky, sometimes it is muddy or green, and in some cases we also got the bloody discharge from the nipple. It's a very common symptom in over area. But lot of females also present with simple pain in breast or pain in armpit. Pain in armpit or lump in armpit is again very common symptom in over area. About 3 days back, we received a patient with only a lump in axilla and there was no lump in her breast. And when we got the affinity of her lump from her axilla, it got positive results that ductal carcinoma in that lump which was present in only axilla. Then many patients present while they were lactating that they have abscess in their breast, and they present with redness or tenderness and all the features of that inflammation, and being treated by many quacks or many periphery or GPs as the infection or simple mastitis of the breast, but they actually have underlying carcinoma of the breast. That is why we are spreading this awareness. Even the small symptoms, redness, pain, even with pus formation of cancer can present. So they should be referred to a proper clinic for then further checkup. Then early detection is why needed, because with the change of time, with this advent in the treatment, now cancer is becoming curable. If we get an early detection, then 5-year survival rate improves from 30% to more than 98%. We are seeing many ladies who got early detection of cancer and now spending their life completely normal as before cancer after getting the treatment. So this is why we are spreading this awareness that as much as early you will seek the medical advice, you will start the treatment, cure will be better. Now the key to early detection is always screening. Screening means that the detection of a disease in normal population, apparently normal population. So first thing which we spread, we are giving awareness over community through our social media, over multiple sessions in schools, colleges, universities, in technical colleges, that all ladies should do their self-examination. Every month self-examination. Those ladies who are going through their cycles or who are there in fertile life, they should do this self-examination at the end of their menstrual cycle, because this is the time where breast swelling is minimum, breast is mostly in its normal shape and normal physiology. And for those who are post-menopause, we guide them to set just a date, either it is 1st of month, 5th of month, 10th of month, any date, but one date of every month, in which you do their self-examination. And now how to do their self-examination, this is a 5-step simple method. Stand in front of the mirror. First of all, keeping your arms on the side of your body and look at the mirror about the comparative size and shape of the breast. Is there any bump or any dimpling in the breast? Is there any area of redness, any area of puckering? Shape of the nipple, level of both nipples, is it equal? Then arms on the hips, and third is arm above the head. This arm above the head will show any small mass adherent to the muscles. It will be visible when a woman keeps her arms above the head, and any under mammary area which will maybe not visible in case of the pendulous breast in keeping arms on the side of the body. Then palpate your breast while lying down on the bed in circular movement in such a way that the breast is palpated in such a way that a woman should never miss any part of the breast, covering all the quadrants behind the nipple and also the axilla of the patient. Must palpate the axilla using right hand for the left breast and left hand for the right breast. Again, in the standing position, do the same process and also do the palpation of the axilla. So this was all self-examination, but in nowadays when we are seeing a lot of cases, we advise our females that although self-examination is a good practice, but in case of any suspicion, must take the medical checkup. You may miss any lump, you may miss any symptom which may be dangerous in the future. So especially in those cases where the family history is positive, where there are other risk factors like obesity, like low physical activity, working ladies having night shifts, in them we educate them to take regular medical checkup. Now medical checkup is both for screening and as well as the final diagnosis of the breast cancer. This consists of 3 steps. First of all, history and clinical examination, then radiological investigation and histopathological investigation. History and clinical examination is very important by a trained doctor. Surgeon preferably, and students of a surgeon or postgraduate training always available in medical emergency units and in our OPDs. And they should get complete and detailed history, personal as well as family. Personal history of dietary habits, of physical activity, history of oral contraceptives, hormone replacement therapy, each and every.
Please
Then-
mute your mics. Continue, Dr. Naid.
Okay. Then family history. Family history is again very important, not about only the breast cancer, but also there is association of 3-4 cancers, that is the cancer of ovaries, colon, and prostate. These 4 cancers, they are in mostly groups. Then always take any cancer, history of any cancer. Most of our breast, any cancer, then complete breast examination as well as examination of axilla. In case of any positive finding, must do the examination of abdomen for size of liver as well as the bony examination of the patient. Followed by radiological investigations, ultrasonography or mammograms. Although ultrasonography was not initially added in the screening program, but now we are seeing that ultrasound is easily available, it is cheap, and it is taking a lot of cases. Now in our area, we are taking it as the first line tool for screening purposes as well as diagnostic purposes, and we have competent sonologists in our areas. In ultrasound, they give us either BIRAD 1, 2, 3, 4, and 5 very clearly, which is helping clinicians in diagnosing these breast carcinomas. Then mammography. Mammography is the X-ray picture of the breast, easily available. Although there are many recommendations that don't do before 35 years, but now in cases who are at high risk cases are those who have positive family history in their first degree relations, who have suffered carcinoma in other breast or in any other part of the body, or who are at high risk factor of this carcinoma breast. They should get mammography even on a small symptom of the breast cancer. A mammography is good because it can pick up a cancer about 2 to 3 years before it is palpable to a person or to a doctor. Then coming to MRI and CT scan. Although MRI is better than CT scan in soft tissue screening, but soft tissue diagnosing, sorry. But MRI is very expensive. Patient has to lie about 45 minutes prone on a table, which sometimes become difficult for a patient. So CT scan, although it has less, but it is easily available, cheap in comparison to MRI, and early diagnosis, it helps a lot. So then finally coming to the tissue investigation. When we pick up a positive case in our screening process, or when a person comes with some symptoms and we make a diagnosis, then 100% diagnosis is made by our tissue investigation, which has a range coming from fine needle aspiration cytology, then core biopsies, ultrasound guided core biopsies, stereotactic and external biopsies. External biopsies are now becoming rare because fine needle aspiration cytologies are improving. Then core biopsy is a better option because it is less traumatic, gets some small time, and it gives us almost all the information which we want to get from the external biopsy. Fine needle aspiration cytology again is very good tool, although the range of false negative reports is high in fine needle aspiration cytology, but in cases where it gives us a positive response, then it is a very good tool. Among the core biopsies, we have true cut needles and monopty guns. These core biopsies, in case of large lumps, we can do without help of ultrasound or CT scan machine. And in the lumps which are not palpable, or we think that we can target them wrongly, we can take the help of the ultrasound or the CT scan, which is called as the stereotactic biopsy. So thank you very much. And this was
Thank
all
you very
about
much, Dr. Naheed, and very precise presentation. Now, because now we have seen the preventive measures, we have seen the risk factors, diagnosis, self-assessment. As a pathologist, I know that FNSC and core biopsy is very important. But now, when after the diagnosis, what you will deal with the breast cancer, Dr. Farzana, आप क्या करेंगे हम जब आपका केस आ गया आपके पास? Dr. Farzana is Associate Professor, Azad Jammu Kashmir Medical College, Muzaffarabad, and working as Associate Professor Surgeon in AIMS. Ji, Dr. Farzana.
Yes, sir.
Started.
Bismillahirrahmanirrahim. Assalamu alaikum to
Walaikum
all of
salam.
you. Hopefully you are all are doing well. Today we are here to discuss different aspects of the carcinoma breast. As this is the October month that is being celebrated for the awareness of the carcinoma breast all over the world. We are lucky here that we have principal of AJK, Professor Mulazim Hussain Bukhari, who is very enthusiastic and he is very keen to spread this awareness message. Regarding awareness program, मैं थोड़ी बात करना चाहूँगी कि हमने like कोरोना जो था सीजन उसमें 2020 में हमने ये अवेयरनेस प्रोग्राम स्टार्ट किया था कि जब ओपीडीज बंद थी और ये पेशेंट्स इनके लिए हम ये प्रोग्राम करना चाह रहे थे और यानी इनकी ट्रीटमेंट किसी तरह से भी अफेक्ट ना हो तो वहां से लेके हम इसको चले और अभी तक अल्हम्दुलिल्लाह वी आर वेरी सक्सेसफुल स्प्रेडिंग दिस मैसेज कि अभी फ्रॉम द प्रिवेंशन टू दी डायग्नोसिस स्क्रीनिंग अब हम ट्रीटमेंट तक आ चुके हैं कि अब हम ट्रीटमेंट की अवेयरनेस देना चाह रहे हैं सो
we are also going door to door since 25th 26th 27
yes
with the
और
team.
इसमें ऑब्वियसली के प्रिंसिपल साहब का बहुत बड़ा रोल है कि वो अभी हमें इस लेवल तक लेकर आए तो रिगार्डिंग ट्रीटमेंट It's not moving.
कोई बात नहीं आप बोलते रहें कोई बात नहीं बोलते रहें
Sir,
सेम इशू चलें आप
Okay.
अपनी उसको स्क्रीनिंग को आप वो करते रहें अपना बोलते रहें अपने हिसाब से
सर मैं इसको जरा दोबारा शेयर कर लूं
नहीं आप ऐसे इसको 1 2 3 नीचे करते रहें कोई इशू हो आ जाता है जी टाइम थोड़ा है हमारे पास जी ब्रेस्ट कैंसर
Yes, sir. As we all know that this is the most common cancer in women worldwide, and breast cancer is the major killer for the young ladies, and it is the second leading cause of cancer death after carcinoma lungs. And its treatment depends upon the stage of the disease. Now, coming towards the staging of the disease, we use TNM staging. T is for the tumor size, N is for the lymph node involvement, and M is for the metastasis, distant metastasis. In the T component, this Tx is primary tumor that cannot be assessed, and T0 is no evidence of primary tumor. Ti is when there is carcinoma in situ. In T2, it is in T1, it is up to 2 centimeter in size, and T2, 3 to 5 centimeter. In T3, it is up to 5 centimeter, and T4 denotes any size of tumor with extension to the chest wall or the skin involvement. While the lymph nodes in NNEX, the regional lymph nodes, they cannot be assessed. And in N0, no regional lymph node metastasis is there, means कोई lymph node palpable नहीं होता. In N1, we get ipsilateral mobile axillary lymph nodes. These are ipsilateral, these are mobile. While in N2, they are now fixed clinically or they are mated together forming a mass. In N3, these are the infraclavicular lymph nodes that are palpable or the axillary lymph node with ipsilateral internal memory lymph nodes. Now the internal memory lymph nodes, they are involved in this disease. Now it is N3. While in the metastasis component, M0 denotes no metastasis. While in M1, we have distant metastasis to the liver or lung or bones or brain or skin. Depending upon the TNM classification, we stage this disease as stage 0 to stage 4. Stage 0 is the disease when there is tumor in situ, but there is no lymph node involvement and no metastasis. In stage 1, we only have a breast lump in the breast that is of the size of less than 2 centimeter, but without lymph node involvement. while in stage 2, we get lymph node involvement. It is along with the increase in the size, that is from 2 to 5 centimeter. Now stage 2 is further divided into A and B, depending upon the different combination of the T component and N component. And here we don't get any distant metastasis. When we talk about stage 3, it is further divided into A, B, C, again, depending upon the size of the tumor and the involvement of the axillary lymph nodes. And it ranges from T0 to NET and from N0 to N3. So here we get a tumor that may be larger size, more than 5 centimeter, and we get lymph nodes that are mated together, and we may get internal memory lymph nodes as well. So it is the advanced disease. While in stage 4 is the disease where there's any T, there's any N, but with the distant metastasis. So here the stage 1 and 2 are the stages. They are included in the early breast cancer with a very good treatment outcome. When it is the localized disease to the breast and axilla, so we can deal it with the good results. Now, there are different treatment options that are used in the treatment of the carcinoma of breast, but the mainstay of this treatment is the surgery in early stages of the breast cancers. The other treatment options we get are the chemotherapy, radiotherapy, maybe hormonal therapy we have to use, and targeted therapy and immunotherapy. We can see that this surgery is the first line of attack against breast cancer. And inside the surgical options, we have different options that can help these patients, including the breast conservative surgery. This is the nowadays worldwide, it is recommended for the early stage disease, BCS, where we can conserve the breast. And mastectomy, where whole of the breast tissue is removed. Lumpectomy, when the lump is removed along with the 1 centimeter tumor-free margin. And in axillary dissection, we take the axillary lymph nodes out, while breast reconstruction after the mastectomy is needed to maintain the shape. And prophylactic ovarian removal can be recommended according to the need. In mastectomy, modified radical mastectomy is nowadays, it is recommended, while the radical mastectomy is now absoluted. In modified radical mastectomy, whole of the breast tissue along with the axillary dissection level 2 is performed, and later on patient may or may not be followed with the chemotherapy, radiotherapy, or hormone therapy. According to the need of the individual, it is decided. And with mastectomy, it lowers the risk of the recurrence as compared to BCS, breast conservative surgery. Regarding breast conservative surgery, as it is recommended worldwide now to conserve the whole of the breast tissue while removing the tumor with the 1 centimeter tumor-free margin. The advantages are that it preserves most of the appearance and sensation of the breast. It is equivalent to the mastectomy in terms of survival rate. And it preserves much of the appearance, and it is good cosmetically, and it avoids the need for the breast reconstruction later on. So it simplifies the treatment, and it is less invasive, and the recovery time is shorter, it is easier, and the oncologically safe procedure, and there is a minimal post-operative defect and the minimal scarring. So over mastectomy, it has so many advantages, but the thing is that if it is recommended and it is indicated for that particular patient, then we will do breast conservative surgery. And the particularities are that it should be early breast cancer. The tumor size must not be more than 5 centimeters, and patient is willing to have radiotherapy, and radiotherapy is available or not, and the patient is concerned to lose the breast, then BCS is the answer. And if more than one area of the breast is involved in carcinoma, then mastectomy should be performed. And patient should not be pregnant. And if the patient shows a great concern about the peace of mind, that she has greater peace of mind with breast conservative surgery, then this option should be taken. And obviously the surgeon choice depending upon his or her expertise. This is the result of the breast conservative surgery, that once we operate with the removal of the breast lump with tumor-free margin 1 centimeter, the rest of the breast is preserved with the normal shape and appearance and with the minimal scar. After surgery, patient may be advised chemotherapy, and this chemotherapy may be used as neoadjuvant or adjuvant treatment, or as a sandwich treatment. And this chemotherapy, it includes the medicines that stop or they slow the growth of the cancer cells, as well as these medicines, they destroy cancer cells, and they have systemic effect. So it acts on the micrometastasis and on the residual disease. Regarding radiotherapy, radiotherapy may be used not in all the patients, but it is recommended according to the need of the patient. And if she is a high-risk patient or there is residual disease, so we will use the radiotherapy. Here, high energy radiations are used. They kill cancer cells and they shrink tumor. These are X-rays, and these X-rays, they cause damage to DNA of cancer cells. And they can be used in all the stages of carcinoma breast, stage 1 to stage 4. In early stages, radiotherapy destroys residual tumor, it reduces recurrence, it avoids tumor spread. And in unresectable tumors, it is used in the treatment of metastasis as well, where it relieves pain. And in case of hormonal therapy, these are anti-estrogen and endocrine therapy. They block either the production or the effect of the estrogen on the tumor cells. And about 66% cases, they have receptors for the estrogen and progesterone. So they are receptor positive patients where we can use hormonal therapy. The commonly used medicines are letrozole with the name of Femara and tamoxifen, and they are used for 5 years. The hormonal therapy is also used to shrink the tumor, and as neoadjuvant therapy it is used, and it is used to reduce recurrence rate, to stop the advanced stage cancer from growing, and to reduce the risk of a first diagnosis. Next is target therapy. This target therapy, it targets specific characteristics of cancer cells, like the protein that allows cancer cells to grow in a rapid or abnormal way, like HER2. So ये use होती है target therapy, usually with the name of Herceptin, that is trastuzumab, an antibiotic, and it is anti-HER2 component, and in HER2 positive breast cancer it is used. Again, it is used in all the stages of the breast cancer, from early to metastatic disease, and have very dramatic effects. After the treatment, patient is advised for follow-up on annual basis with the mammography and physical exam to see any recurrence of the disease. So far, this is about the treatment of the breast cancer.
Thank you so much, Dr. Farzana. Now, As a pathologist, I think there are so many questions that with the collaboration of pathologists, surgeons, and the community medicine, because this breast cancer we can control only and only when we have a multidisciplinary approach. My first question to the Iram Gilani from my side. Dr. Iram Gilani, you are there?
Ji, sir.
Okay. What you think about the role of prevention? What you think the role of prevention in controlling the breast cancer in Kashmir?
Thank you, sir. It is a very important question. Sir, as I highlighted in my presentation, that only 5 to 10% of the breast cancer cases, they are hereditary. So by prevention, we can target 90 to 95% of the cases, breast cancer cases.
Okay, my question to the Dr. Naheed, one of my students, she was doctor and King Edward Medical University, and she died, she was of 28 years. The presentation was very interesting, and she started the lump, palpation of the lump, and that lump was painless. And you have told that most of it starts from the pain. What do you think when the lump is painless, and how should be processed, progressed, and presented to the doctor or something? Dr. Naheed Akhtar? Naheed Akram? Dr. Naheed? You can unmute.
Yes, sir. Yes, sir. Sir, most of the time, the lumps of the breast carcinoma, they are painless. In our area, I mentioned this thing, that in our area, the lumps are presenting with the pain. But worldwide, when we see, and in even our books, when we read about it, these are the painless lumps. And many patients present with the painless lumps, and that is why they are least bothered. Yes, we have a lump in our breast, but it is not causing any problem. Patients give us such history that this is not causing any problem. So that is why we are not seeking any medical advice. So we have to tell this thing.
And Dr. Naheed, there is another problem as a pathologist, I feel. Sometimes there is no lump.
Yes, sir. Sir,
And
this is yes, sir. Sir, here the screening comes. That there is no lump, but patient is at risk. That is why we are starting this awareness program. That we are living in an area which is overall high risk for breast cancer. As yesterday, I operated a female, 14 years old, with highly suspicious lump. That lump was almost 9 into 8 centimeters in diameter, and that was totally carcinoma-like lump. And I'm now waiting for the histopathology. It means that we are living in an area where we have to identify over these factors first. Here, every lady is at risk. So we are spreading this awareness that every lady should come in this screening program. Not only those who are labeled as high risk, who have family history, who are obese, who are having low physical activity, or working ladies. Every lady should come in the screening program, should proceed with self-examination. If not getting any lump, come to a doctor. Even doctor is not able to palpate a lump, then proceed for at least a single ultrasound in an year. This is very easy for every person, because we have lot of radiologists in both our major hospitals, Abbas Institute and CMH, and also a lot of private setups. Not in our area, everywhere now ultrasound is easily available. Every lady should be given an awareness that at least get one ultrasound in an year about your breast and keep it in a file, and then fix this month, this date for the next year, and again check it next year, and again keep it in your record. This will make a serial record of that patient. And ultrasound also gets a lump almost 9 months to 1 year before it is palpable. So it is easy tool which can help in diagnosing these impalpable lumps.
Okay, thank you. Dr. Fardana, before I ask the Dr. Sajjan, my question to you is that,
Yes,
one question is that, this question will have sub-segments. No doubt the staging is very important. but we also recommend that the grading is very important and choice of the treatment. What do you think about the immunotherapy? Immunotherapy. Is there
Sir,
any role of immunotherapy in breast cancer?
Yes, sir, immunotherapy has a role. It acts like the antibodies, and it targets the targeted cells. And
You
the
mean
greater view
targeted
shows,
therapy is similar to the immunotherapy or it is different?
sir, although there is a difference, but again, the results are the same. And the mechanism is especially, it is relevant to each other.
Okay, have you seen some change in breast cancer patient in Azad Jammu Kashmir and in Pakistan?
Yes, sir. There was a difference. Like previously, when we see the literature, it always says that it is the disease of the older age. But here we see that even the patients with in the third decade, they are there in 20s. We deal with them, and there are chances to have this disease in these earlier ages women as well. And also the trends are very much changed here, as we are lack of the resources as well. Like even in AIMS we don't have mammography. Although we are dealing with these patients, we have pretty much good results of the ultrasound study, but again we are lack of this mammography, which is the gold standard all over the world.
Okay,
So we have to improve our setup, and especially I would like to talk about MDT, multidisciplinary team approach, which is we are very much deficient in that. Still, we previously we announced it in the AIMS, but with the very small number of members which should be in the MDT. Right now we have a surgeon, medical specialist, radiologist, oncologist, pathologist, or I mean 2 or 3 more members, but we don't have that much long list that are participating to have good outcome of the treatment. So in future we have to give some concentration and attention towards this important component of the oncology treatment.
thank you. Dr. Sajjad Ahmed, you want to ask the question? You have raised the hand. Dr. Sajjad.
Assalamualaikum, sir.
Sir, अपनी ज़ियारत करा दें. Dr. Sajjad, can you start? You can ask the question.
Sir.
Yes, Dr. Sajjad Baloch is basically professor of histopathology. Yes.
सर जैसा कि हम सबको मालूम है कि ये अवेयरनेस का मंथ है ब्रेस्ट के हवाले से, और ये पिछले 2-3 सालों से बड़ी अच्छी एक कैंपेन शुरू है, लेकिन इसमें थोड़ा सा इशू ये आ रहा है कि जी जैसे कि आजकल आप एक मैसेज भी सोशल मीडिया पे काफ़ी गर्दिश कर रहा था, जिसमें वो एक सोशियोलॉजी की तालिबात भी उन्होंने किया, तो हम इस वक्त जो प्रॉब्लम है पाकिस्तान में बेसिकली अवेयरनेस के हवाले से है। तो अवेयरनेस के हवाले से मैं ये कहना चाहता हूँ कि चूँकि मेन चीज़ ये है कि वो जो फीमेल है अपने घर में या अपने रिलेटिव्स को बताने में शर्माती है, तो मैं उस दिन हमारे पिछले हफ्ते अपने कॉलेज में जो है ब्रेस्ट अवेयरनेस सेमिनार किया, और उसमें भी यही चीज़ बार बार हाईलाइट हो रही, क्योंकि अवेयरनेस के हवाले से ट्रीटमेंट के और बाकी चीज़ें तो सारी ठीक है, डॉक्टर्स से और सबको हमें भी पता है, जब पेशेंट आएगा तो तब की बात है, फिर पेशेंट जब आता है 4th स्टेज में तो फिर ट्रीटमेंट भी काफ़ी हद तक मुश्किल बल्कि तकरीबन नामुमकिन हो जाती है। तो मैं अवेयरनेस के हवाले से एक मैसेज वहाँ पे दिया था कि जी ये बेसिकली शर्मीली मौत है, जैसे हम कहते हैं से नो टू करेक्शन, तो इसको से नो टू शर्मीली मौत कहा जाए ना। और दूसरी बात
से नो
तो शर्मीली मौत,
ओके
मैंने शर्मीली मौत है।
ठीक है।
और दूसरी चीज जो मैं कहना चाहता कि जी जो एज जो यंग एज में 20 साल में और 18 से 20 फाइब्रोएडिनोमा जब हम डायग्नोज कर देते हैं, तो ये मेरा बेसिकली सर्जन से क्वेश्चन है, क्या सारे फाइब्रोएडिनोमा को फिर उसकी सर्जरी उसको रिमूव होना चाहिए या उसके लिए कोई अल्टरनेटिव ट्रीटमेंट भी आप यूज कर सकते हैं उसके अंदर? तो ये मेरा सर्जन से क्वेश्चन था। और दूसरा एक और क्वेश्चन था कि जी ये जो अपना चले सर्जन साहब ये जवाब दे दे तो मैं दूसरा क्वेश्चन के सर आपसे करूँ।
जी डॉक्टर फरजाना, कैन यू say the
yes, sir.
treatment of the fibroadenoma?
सर फाइब्रोएडिनोमा के लिए ये है कि
Every fibroadenoma should be operated.
sir, usually we operate on the fibroadenoma with the size above 2 centimeter. But again, if the patient is anxious or the family is anxious and they are reporting again and again, and they are not easy with it, and there is no peace of mind having this small fibroadenoma, then we remove it and it is indicated.
Okay, you have any other
Thank you.
questions, Sajjad?
यस सर। दूसरी चीज एक और वहाँ पे हमने सजेशन भी दी अपने एरिया में भी, और बाकी आपसे सर थोड़ा सा उसके बारे में इंफॉर्मेशन लेना चाहता हूँ। एक है कैंसर रजिस्ट्री। तो क्योंकि हमारा अपना लोकल रीजन का डेटा जो है हमारे पास अवेलेबल बहुत या है नहीं या बिल्कुल कम है, तो क्या हमारा कोई कैंसर रजिस्ट्री प्रोग्राम ऐसा है? ये नंबर 1। नंबर 2, दूसरी ये चीज थी कि एक ट्यूमर बोर्ड जो रीजनल बेस भी हो सकता है, पाकिस्तान बेस भी हो सकता है, कि वो ट्यूमर बोर्ड बनाया जाए जो कि मुख्तलिफ पेशेंट्स को जो है एवेल्युएशन करके फिर उसको उस बोर्ड के अंदर डिस्कस किया जाए। वो रीजनल भी हो सकता है, पाकिस्तान बेस पे भी हो सकता है। उससे ज्यादा अच्छा कमेंट आप कर लेंगे सर।
Yes, we have a registry board. We started this program, but unfortunately, I think it has become regional. Aga Khan has started its own registry and Shaukat Khanum has started its own registry. We will raise this voice to the world, to the Pakistan and even the WHO that the registry program should be comparatively for the all over the world and the Pakistan. Dr. Iram Gilani, you have raised the question.
जी सर, सर आई वांटेड टू थैंक डॉक्टर सजाद के उन्होंने इतना एम्फसाइज किया अवेयरनेस क्रिएशन पे। आई टोटली एग्री विद हिम एंड ये बात भी सही है कि हमारी कल्चरल ये है नॉर्म्स है कि इस तरह की जो बीमारी है उसको बताते वक्त होता है। मतलब इसका मतलब है कि आर अवेयरनेस कैंपेन शुड इनकॉर्पोरेट दीज एलिमेंट्स एज वेल। तो जो उनका रजिस्ट्री वाला है सर, while I was preparing this presentation, तो मैंने ये नोटिस किया कि we do not have a national cancer registry.
कैंसर रजिस्ट्री नहीं है।
जी सर, there is no national। वो आपने बिल्कुल सही सर पॉइंट आउट किया कि जो
ये हम डॉक्टर सलमा कुंदी को कहते हैं ये आवाज पीएमए के लेवल पे रेस करें कि नेशनल उस पे वो किया जाए।
जी सर, जी सर।
थैंक यू सर, थैंक यू सर।
We have a friend, Dr. Mahadev Haranai. Can you give some comments, Dr. Mahadev Haranai? Dr. Mahadev? Okay. If anybody want to ask the question, Dr. Professor Abid Karim, Dr. Shamsa, anybody want to ask the question?
Yes, sir, I want to make a comment.
Oh, yes.
Thank you, Dr. Sajjad. He has raised a voice for the awareness and pointing out about the registry. Sir, we are running the breast clinic and about the data, he was interested in that. Now we are maintaining the register for the data from that breast clinic. And I will make request to you to help us to make our team and for the registry of this oncological team.
Professor Salma Kundi, head of the Department of Physiology, principal of Women Medical College and president of PMA and vice president of Pakistan Physiological Society, Dr. Salma Kundi.
Jazakallah khair, Professor Mulazim Saab. Thank you for giving me the opportunity. I have a question.
Madam.
Thank you very much, Naiji. It's because of you and because of everyone who participates here. मेरा एक ये क्वेश्चन है कि इंशाल्लाह ट्यूमर बोर्ड्स भी बन जाएंगे, हमारी रजिस्ट्री भी बन जाएगी, पीएमए जरूर आवाज उठाएगी। मेरा सिंपल एक क्वेश्चन है कि जेनेटिक म्यूटेशंस के ऊपर कुछ पाकिस्तान में काम हो रहा है? जैसे मुझे लगता है BRCA1 और 2 कहीं पर टेस्टिंग भी नहीं हो रही। पिछली दफा मैंने सुना था लाहौर में कोई सेंटर खुल गया है।
जी जी
मतलब ये
मैं
बहुत
जवाब
बेसिक
देता हूँ।
चीजें हैं जो होनी चाहिए पाकिस्तान में। दूसरा ये
अ,
जेनेटिक एबरेशंस को हम कैसे ओवरकम कर सकते हैं, क्योंकि असली फसाद तो फिर यहाँ से निकल रहा है ना।
sir, if you allow me, may I answer it?
Yes, you can answer.
जी जी
मैम अभी प्रिंसिपल साहब जो हैं मुलाज़म हुसैन बुखारी साहब, इनकी कोलैबोरेशन से इन्होंने हमें गाइड किया है, तो इंशाल्लाह हम एक प्रोजेक्ट शुरू कर रहे हैं
Yes.
जिसमें हम अपने एरिया में BRCA1 एंड BRCA2 जीन्स जो हैं इनकी सैम्पलिंग हम स्टार्ट कर रहे हैं, क्योंकि हमारे एरिया में अभी तक हमें कोई ऐसा रिस्क फैक्टर नहीं मिला। एंड यंग लेडीज जिनकी मिनारकी अगर 12 इयर्स पे है और उनको कार्सिनोमा डायग्नोज हो रहा है 20 इयर्स पे, उनका एस्ट्रोजन एक्सपोजर कितना हुआ है कि जिस पे उन्होंने कार्सिनोमा डेवलप कर लिया, या उनमें कितनी जो है, और तो उनमें मोस्ट प्रोबेबली फैक्टर हमें अपने एरिया में BRCA1 BRCA2 जीन म्यूटेशन ही लग रहा है। तो सर की गाइडेंस में हम इंशाल्लाह ये प्रोजेक्ट शुरू कर रहे हैं कि जिसमें हम इसकी
Yes, we
सैम्पलिंग
are
स्टार्ट
inviting
करेंगे।
President, and he will definitely, Professor Sarma Kundi, I am afraid that at national level, there is no any lab to start this national work. And you have to also work to raise the voice to starting this national level. But NIH
Inshallah.
has started this program, but due to COVID and other diseases like Ebola and this, that is why the NIH not, I think, so much busier than. The objective of these webinar is also to give the awareness and to give the voice, to raise the voice to against the many diseases. And Salma Kodi, Professor Salma Kodi, you are the president, and inshallah we will raise this. We will also write a letter. We will also write a paper on this, these questions, that these things are deficient in. And data of the Pakistan and all over the world, like our neighbors countries, India, Iran, Saudi Arabia, and should be compared, which are the most factors. We at Kashmir, we are going to start very soon in November, genetic lab to test these factors. And Dr. Abid Karim, you have raised the hand.
Yes, sir. Assalamu alaikum, sir. Sir, first of all, sir, yes, I sir, extend my condolence on the sad demise of your uncle Mamu. Allah Taala उनकी मग़फ़िरत फरमाए, उनको जन्नत में जगह अता फरमाए और आपको सब्र जमील दे।
Thank you so
और
much.
secondly, sir, we have started our research work regarding the breast cancer in our department with collaboration with community medicine and gynae department. Inshallah, under your umbrella, we will continue it, and soon we will give you the progress regarding that. Thank you.
Inshallah, we are next from the, we are going door to door to raise this voice from 25th, 26th, 27th. And Dr. Nutt, over to you, Professor Salma Kundi, to start today's webinar.
Okay, thank you so much, Professor Mulazim Saab. On behalf of PMA, the Pakistan Physiological Society, the Pakistan Association of Pathology, Azad Jammu Kashmir Medical College, Muzaffarabad, and Women Medical College, Ahmedabad, I thank all the speakers, all the participants, especially Professor Dr. Iram Gilani, Associate Professor Dr. Nahid Akhtar, and Associate Professor Dr. Farzana Sabir. And special thanks to you, Professor Mulazim Saab, and also to our IT manager, Wadeed, because it is a team effort. And we will take, they were excellent speakers, Iram, Nahid, and Farzana, and you've raised an awareness at a level which is needed. All these are taped, and then all our students listen to it. So it's a very good take-home message that we should not die a Sharmili death, as Dr. Sajjad pointed out.
Salma Kundi, can I give one suggestion to you?
Ji, bilkul.
Can we fix a day that your teachers come to my college to give the awareness to my female students, and my teachers can go to the Ahmedabad to give the awareness to your students?
Anytime, you are most welcome. But right now, at this moment, our 4 years are on prep leaves, and the final year will leave after 2 weeks.
Yes,
So I
anytime,
think this
inshallah,
can
we
be
have a time.
arranged in May. We will do it in May, inshallah. And take home message for the PMA is that we will write to the government to have different labs for genetic testings, BRCA genes, and there's this Lynch syndrome, which can also cause CA in the breast with CA of the uterus and colon and stomach and everything. So we should be tested and we should know what we lack and how we can overcome these gene defects. I think
That's
all you
correct.
pathologists need to be trained in that. We need some genetic engineering in our bodies now. Probably all the inorganic food, all the pesticides have played a havoc with our health and with our DNAs. Anyway, may Allah grant health to all, and may Allah save us from cancer and from all these bad diseases. Allah bless you all, and Allah bless Pakistan. Thank you
Thank
so
you so
much.
much. Thank you so much. sir.
Thank you so
Allah
much.
Hafiz. Allah Hafiz. Thank you so
Allah
much.
Hafiz.
Thank you.